So I wanted to welcome everybody to our bridging session. And so I think as you guys have seen, what we have is that we had a morning that was really filled with discussing outbreaks among the outbreaks that we've seen with syphilis and really what the CFAR's role in that really across the United States. In the afternoon, we have an afternoon really focused on implementation science, and a perfect bridge to that is Patrick Sullivan really giving a talk about implementing new strategies and new approaches for syphilis. So I think actually Patrick Sullivan may be known to many of you. He is a professor at Emory. Before that, he was at the CDC for I think 14 years, and then before that was in the Vaccine Trial Network and had among other positions. I'll say as somebody who's collaborated on a couple of grants with Patrick, he's incredibly thoughtful. He is not just in terms of advancing methods, but really just sort of content questions that I think are relevant. And so as implementation research methods have emerged, this is really a space that he's been in for a long time. I think before it was clearly delineated within the space of implementation research methods. When we saw a new piece that Patrick had put out about implementing syphilis plans in the context of public health departments, our implementation scientific working group with Larry Chang and Lois and Melissa Davey Rothwell, together with Jakia and others, really felt like that would be a perfect bridging session. And so Patrick will give a talk, and it's going to be short. It's intended to be sort of in that 20 to 25 minute range, and we still hope to have about 20 minutes of conversation after that. And I think there's a lot of expertise in the room, after which Larry will introduce our afternoon sessions focused on implementation and research methods. So just to welcome Patrick Sullivan. Thanks.
Thank you, Steph. That's very kind, and thanks for the invitation to be here. And seeing the lineup for the morning and hearing parts of the morning session, it's interesting to come and hear people who have really deep expertise in the clinical programs, folks in the health departments, and in Baltimore you have this nice marriage of interactions with the health department. Not every place has that, so seeing the deep expertise in the public health delivery and the clinical science, and we heard about epidemiology this morning and a number of areas. It's a little intimidating to come before a group like this because I've lived in all of those worlds, but at a shallow level. So maybe that's our functional definition of implementation science. I do think, as Steph said, that I feel fortunate to have had the experience of training at CDC and working in surveillance at CDC. And as we talk about implementation science, I feel like these are a lot of the issues that we talked about without that name for many years. I've been doing this with Nanette for many years. And so it really is a way to put a framework around just having a broader discussion. So I had the honor of sort of co-leading one of the tracks at this syphilis summit about a year and a half ago on implementation. And the chairs of the conference commissioned a special issue of STD that's out now, I think. And so for that, we organized papers from the folks who had been speaking. And this piece that Steph mentioned was meant to be sort of a summary of, what was concluded from those talks. And when I wrote it, I sort of, when you draft these thought pieces, think like, what's new here? What's going to make people think about things in a different way? And so the reactions to it were interesting, just from the extent that people said, like, wow, it's nice to line up sort of what's going on with the diagnostics and with the community and where access points are. But I think that is, I guess, the nature of melding this sort of epi and clinical and how care is delivered together. I mean, in terms of the focus of the morning, which is HIV and syphilis, I just want to stage set a little bit by saying that although we've made great progress in the HIV epidemic overall with declines in new diagnoses, that during that same period, this is through 2014, there's been a small uptick in MSM and a concerning uptick in Black and Latino Hispanic MSM and a staggering increase in young Black and Latino MSM aged 13 to 24. So we have an ongoing epidemic in MSM that's in some ways, getting hyper concentrated in young men of color. And at the same time, if we put syphilis in historical terms, going back to epidemics that occurred certainly in the 40s and then around the time of the emergence and identification of the HIV virus, we're sort of historically not in such a bad place. But you can see that since about 2011, there's this uptake in total syphilis that's visible even at the population level. It's not a hard case to make to this group, but everywhere we turn, we are reminded that HIV and STI prevention are stronger together for a number of reasons. We're trying to serve many of the same populations with these services. We have many of the same service points. And then I think there's this compelling issue of the biological interactions. And one area there's been a little bit of emerging and science is coming from several different approaches is this issue of the percent of HIV infections that are attributable to asymptomatic rectal STIs. So my colleague Colleen Kelly used data from one of our early cohorts to estimate from cohort data that about 15% of new HIV infections are attributable. This is the population attributable fraction. She estimated 15%. Barbie et al. From Matt Golden's group estimated 14% using a case control approach in Seattle. Our colleague Jeb Jones used an agent-based modeling approach to estimate this in a model and came up with 10%. So now you have a sort of cohort study, a case control study, a model-based study, and they're all landing in this range. And from an epi perspective, the exciting thing about population attributable fraction is you can translate that directly to if we identify and treat these, we could get rid of 10 to 15% of infections just by that step. So obviously we're talking about syphilis, and these are integrated clinical services, but there is that sort of piece of biological interactions. If we sort of take a midpoint of this, we could probably avert 3,000 to 4,000 new HIV infections a year in MSM, and each year save potential lifetime treatment costs of about $1.5 billion. Do a lot of testing for that. So in thinking of this idea of implementing a new action plan, some of the thought process that I went through is first thinking about the epidemiology and what's the epi of infection in the subgroup. How are we already engaging populations? What are the service points? Who are the providers? What are the opportunities to intervene? What are the related programs and services? Are there populations where there's really a main access point, or should we be looking at multiple opportunities? What the diagnostic services based on that service location? And trying to ballpark what are reasonable programmatic aims. So again, just being guided by the data, if we start to think about this in terms of risk buckets, you can see where this shows where people were diagnosed with syphilis during 2016, and I started out talking about MSM, but it's worthwhile saying that correctional facilities are sort of key populations, especially for men who have sex with women and for women. For MSM, private physicians are a sort of primary testing site. So it speaks to the range of providers who are going to need to get engaged around education about screening practices. A first question for these kind of programs is, what can we really aim for? Is it control, where we say we're going to reduce disease incidence or prevalence in a certain area to a level that's acceptable, whatever that means? You can fill in your own definition of that. Or is it elimination, to completely stop incidence in a geographically defined area? That disease-causing agent may persist, and so once you get that program in place, you've got to keep on. And maybe a longer-term goal is eradication, removing it from the natural environment. And someday our grandkids will think about extinction. So these are congenital syphilis cases depicted in the blue bars, and the rate of primary and secondary syphilis in women depicted in the line. So you can see that, just the order of magnitude. In 2016, about 27,000, 28,000 new syphilis diagnoses, and of those, a little over 600 occurring as congenital syphilis cases. And generally, again, as you might expect, the rate of, or the number of congenital syphilis cases tracks along with the PNS rate in women. In the case of women and congenital syphilis, the clinical consequences are devastating. But the points of clinical intervention actually may be quite accessible. Pregnant women are already being screened for other conditions, including HIV. Most women are engaged in clinical care. And so here I think the goal really should be elimination. And in terms of a strategy for this, when you have 600 cases a year, I think we could just treat each one of those as a sentinel event. If a congenital syphilis case occurs, get in there, look at the records, interview the doctor, interview the mother, interview the care system that was in place, and figure out where the system failed that woman and that baby. And by the way, I have the same opinion, which has been shaped largely by my colleagues Jeb Jones and Jim Curran, about deaths for people living with HIV. Every death of a person living with HIV right now should be a sentinel event that we want to understand as its own case study. These are now data that show the cases in men who have sex with men who have sex with women, and women. And so the trend here is that cases among men who have sex with men are sort of separating a little bit in terms of the curve from men who have sex only with women and women. So both the magnitude of the increase is higher and the absolute volume of cases is higher. And this goes along with a trend that's been observed since 2012, and so people try and line that up a little bit with PrEP, the introduction of PrEP. I'll talk a little bit more about PrEP later. And here just the male rate, the female rate, and the male to female rate ratio. So along the bottom, that lower line reflecting that trend in women, that rate in women that we saw on the previous slide, but just again pointing out that rates in men are doing a fundamentally different thing here in terms of their slope, and the male to female rate ratio can be thought of as just a proxy for disproportionate impact in gay men. So I wanted to talk just a bit about HIV testing and MSM, because testing is clearly an important part of our programmatic response. These are data from my colleague Travis Sanchez, who runs an annual survey of about 10,000 MSM in the US using the NHBS questionnaire basically. And just to orient you, these lines are 4 lines, 2 lines for men living with HIV, 2 lines for men not living with HIV. And for men living with HIV, over 70% got STI screening during the year that's depicted here, and about 1 in 4 of them were diagnosed with an STD. Among men who are not living with HIV, that's 40% screening and about 9% diagnoses. So we have a big screening differential gap. And from an implementation science point of view, you got to believe and hope that a lot of that is because men who are living with HIV are getting other care, and this has really been integrated into clinical protocols. I want to point out another just issue for implementation here, which is data from CDC's web-based survey, which was the sort of predecessor to Travis's AMOS study, looked at the use of prevention services comparing rural and urban MSM. And so although the rates of condomless anal sex on the far left are the same for rural men in blue and urban in green, the use of all the prevention services that are needed are consistently less for the men in rural areas, including syphilis testing, including other STD testing. So syphilis and MSM, we see a high and increasing incidence. Despite STI testing recommendations, only 40% of HIV negative MSM have been tested for STIs in the last 12 months. And that's slightly less than those who report testing for HIV. So I'm just thinking from a service perspective, if we're getting 65% testing for HIV, but 40% testing for STI, what are those service locations where men are getting one of those tests but not the other? And part of that may be because in some states and service settings, the funding streams are separate. And so I think this is an issue for our colleagues in health departments. And our colleagues in health departments might say this is an issue for CDC, or maybe it's an issue for all of us. But thinking about, and CDC has been involved even since I was there, so for decades at least, in thinking about this idea of service, programmatic and service integration, and yet we still find places that are doing HIV testing only and referring men for STI testing. In terms of the availability of STI testing, I think in many places you had a great representative of our Atlanta progressive healthcare system, Wendy Armstrong, and certainly there are clinicians who know about this and do it, but we started offering rectal STI testing in one of our cohort studies where we had men come back at 3, 6, 9, baseline 3, 6, 12, 18, 24 months. And we started offering rectal STI testing with self-collected specimens. And we had grave concern that men would not be willing to do a self-administered rectal swab or not just be unwilling to do it. And of the first about 3,000, 2,900 and something, we had 2 refusals. So it's highly acceptable. And when the study ended, we literally had one guy who was weeping because he said he had an undiagnosed rectal STIs that was causing him problems and had been for a long time. And he didn't know where he could continue to get rectal STI screening after the study ended. And so in Atlanta, I'll just say from talking with clients and talking to physicians in private practice, that men sometimes go and seek this testing and are told, men don't need to do that, that's for women, or it's highly specialized and you need to go to you might need to go to a GI doctor to do that, when self-administered rectal swabs are very acceptable. So I think for MSM, the goal is going to have to be control. 15,000 diagnoses a year. And the other sort of structural barrier here is that historically partner services or partner notification has been a key part of STI control. But colleagues in San Francisco have demonstrated just beautifully how, like over this period of increasing syphilis incidence, that the proportion of cases, partners who are known only through apps or screen names has shot up and is the clear majority of partners. And so there are several innovative things that are going on about how we might locate those partners or how health departments might, but that remains a major barrier. So I think the goal here is control and thinking about what a locally acceptable incidence is. And so strategies here, I think better integration with HIV screening. I'm going to talk a bit about mail-out STI kits, training of providers for ocular neurosyphilis, which are these sort of rare but serious complications. And so thinking about training primary care docs, given the low disclosure of male-male sex practices to primary care providers, just flagging them to be looking for these manifestations. So I want to talk about just a few broader issues in syphilis control or elimination. This came up a bit this morning, but surveillance. I have had the privilege of the last 8 or 9 years for working on a site called AIDSview, where with Nanette and with others, where we basically work with all the state health departments and many of the city health departments and CDC to take this rich surveillance data, and we every year we find new nuances to map and new levels of detail. And it's because of the substantial investment the US makes in HIV surveillance that we can really talk about these data at a fine level, and that is used to guide programs. The AIDSview site, Ron Valdesari just wrote a nice paper about how people use AIDSview to implement programs and to ask academic questions. And in the case of STD surveillance, it's historically been much less funded. Some of the things we really want to know, there was a talk about sexual orientation and gender identity earlier, a discussion thread that I'll come back to. So a lot of the nuances that we are used to having for HIV data just aren't available because of the historical levels of funding. And so what you see even in the slides that I showed you is that there's a case reporting system that is universal but pretty shallow, and then supplemental studies, supplemental surveillance networks that drill down in. When you see MSM data, that's because a subset of sites are really collecting those data. With respect to sexual orientation and gender identity, I'm happy to say that this year, the structure for reporting those features for STD cases has been put into the reporting system, the NET system. They're used infrequently, and they're going to have to go through OMB, so add a year. But it's a two-stage process. We could have a 25-minute discussion about the right way to measure this, but what is put into that system is a two-stage question of asking about orientation and then asking about gender identity, current gender identity. And so at least there's now a pathway to have this come into the surveillance system. So just generally, I think it's of all the things that we want to be advocating with our policymakers about at the moment and with our health departments, surveillance is not the most exciting one. But I think in the long term, especially if you're thinking about goals of elimination in areas, it's going to have to be supported by better investments in surveillance. I'm going to talk a bit about PrEP. Is it friend or is it foe for STIs? And I know you already heard this morning from Dr. Gatos about diagnostic tests, and so I'll just touch on that briefly. So PrEP, friend or foe? PrEP might be a friend to STIs, or to STI prevention. It might be a friend to STIs, but it's a friend to STI prevention. Because STI screening is now recommended every 3 months for most of the men who would be indicated for PrEP, so should be testing frequently. It also means opportunities for prevention counseling, condoms, lube, other discussions every 3 months, although we got a reality check, I think, from some of the clinicians who said like the pace of visits is such that those may be luxuries. But importantly, finding and treating STIs, and so that is a tenet of elimination. PrEP also might be a foe, and there's a lot of anecdote, and there are some billboards in some cities about the idea of risk compensation, that if I think I'm protected from HIV, I might abandon condom use, and then I'm at risk for STIs. So I might have increased partners, I might have decreased condom use. And there's a funny feature that we found in our cohort of young black MSM in Atlanta, where we enrolled 300 young black MSM and just offered all of them PrEP without regard to what risks they reported, because they're young black MSM in Atlanta and context matters. 40% of them started PrEP. And so for one, we've had a substantial degree of PrEP stops. And when we ask men why they stop, some of the reasons are they don't like taking a pill every day, or they don't think that at that much risk. But a not infrequent answer is because I got an STI. And so we say, what? That's a reason to double down. But the thinking is that I went on PrEP, I got an STI, and it made me realize that PrEP doesn't protect me from everything, so I'm returning to 100% condom use. And so I think there's a sort of, clinicians just need to be prepared, because you might have the same reaction I did, which is like, what? That's not the way that works. But having a way to say, it's great that you've made this decision that you want to increase condom use, we recommend that people stick with PrEP, like during that period of transition, until you have that discussion with all your partners and whatever the conversation is. All right, so my colleague Sam Janess led this modeling work that's done jointly with CDC to ask what would happen to gonorrhea and chlamydia incidence if we scaled up PrEP to a certain extent. Now, you said this talks about syphilis, and so why are we talking about gonorrhea and chlamydia? The uninspiring answer here is that syphilis is tremendously hard to model in these agent-based models. We have a group that's been working for the year since this was finished to try to figure out how to make syphilis play nicely with the other STDs in the model and allow them to calibrate. But certainly, gonorrhea and chlamydia represent common risk factors, so I think it's worth it as a thought exercise. So the premise here is that we look at different levels of PrEP coverage. I'm going to use mouse, no mouse. So on the horizontal axis is the level of PrEP coverage. And so if you just look out to that 0.8, at 80% PrEP coverage, and the vertical axis is risk compensation. So at 0, the sort of baseline would be nobody increases their behavioral risks if they're on PrEP. So if you get 80% coverage of PrEP, and no risk compensation, and you're doing all this STI testing, you actually would avert 80% or more of gonorrhea and chlamydia according to this model. As you have less PrEP coverage, or as you have more risk compensation, your opportunity to avert infections actually goes down substantially. And I think these models are great for taking an objective approach, for challenging the paradigm, for hypothesis generating, for pissing people off so that they try to disprove find a counterfactual. But at least this suggests that without all the nuances of people's behavior and partner choice and everything else that gets layered in, that the frequent STI testing really should have a palliative effect on infections averted. And as you expect, if you ask the model, well, does the frequency of that STI screening for PrEP care matter? The lowest line, the purple one, is if you're screening people every month. And so basically over time, the incidence rate of these sexually transmitted infections goes way down if you're screening monthly. The current recommendations at the time this was done were 6 months, which is the green band. Now 3 months for the higher risk guys, which is the blue band. So the frequency of screening matters, which you would expect. And then those infections have to be treated. So we would hope for 100% treatment. But if there are lapses between screening and treatment, which can happen for a number of reasons, then you pretty quickly lose the projected benefit. So I know that people are skeptical of these models, and so I sort of put them in along with lived experience, clinical experience, what's really happening in the world, billboards, like all the sources of information around here about this issue of whether PrEP is actually facilitating STIs. I personally give the models a little more weight than the billboards, but you have to make that decision for yourself. The truth is that we know that the follow-up screening is not done always in the way that one might expect it to be done. And there, as I said, there's a lot of other layers of nuance just about who people are using condoms with and not. And so it's really not an all like I don't risk compensate, but I may risk compensate with certain people. And so it's unequivocal if you pool all the PrEP trials that the men on active arm of PrEP trials have about a 25% greater risk of STI diagnoses than those who are not. So data from the world are counter to data from the model. All right, I want to mention, I know that Dr. Gatos already talked about at-home STI testing. I think in the realm of MSM, I hopefully make a slightly different point. So we were inspired at Emory, my colleague Aaron Siegler has really led this work to think about the home access model, the sort of old school rapid test where you do finger stick, mail in a dry blood spot, goes to the lab, get your results back. And so our CFAR now develops and will support any of you with these kits at cost. So we assemble them for the tests that are desired in the study. We bank them, we keep them at Amazon so we can have them delivered with the little Amazon tape. People are concerned about whether it comes with a stamp that says your STI test is here, but it's just, everybody gets 4 boxes from Amazon a day anyway, so this doesn't raise concerns. And then the tests are mailed back to the lab that the investigator chooses. So we're currently collecting urine, rectal swab, pharyngeal swab, and finger stick blood to do the test that you see here. Syphilis, particularly, I just want to mention, is of course the most challenging of these to do. We use a microtube. We get good, sort of good specimen sufficiency with this 100 microliter finger stick. We have a little fun video that coaches them on how to do this. We plan to do a 1-to-4 initial RPR because of the volume. Often they overfill it and we can do a neat initial RPR. But if that 1-to-4 is positive, then we have to send them in to get a draw and get a proper titer because we don't have enough to do that titer. It is a particular issue with MSM because there's a lot of serofast syphilis and these sort of low lingering titers. So I just want to say currently these kits are being used in a number of research studies that are supported by NIH, the Adolescent Trials Network, and CDC. And if any of you are interested, you have local expertise. We sort of are doing these at a service and are getting some efficiency of volume. So if we can help support research projects from our CFAR, we're happy to. I just want to give you a little blip of data, which is that we're working with CDC on M-Cubed, which is a comprehensive prevention app. It's not just focused on testing, but on a number of aspects of sexual health for MSM. With CDC, this is a 1,200-person study that will finish enrolling at the end of the month in 3 cities, Atlanta, Detroit, New York. And men get the app and they're on it for 3 months. So we're in the middle of follow-up. Most of the men haven't hit 3 months. But just looking at the time we've accrued, already 46% of them have ordered HIV tests and 40% have ordered STI test kits. Again, a slightly higher uptake as we see every time we do this in HIV than STI test kits. Maybe we should bundle these together and just say if you order, we're going to send both. But really, these are for home delivery. So ordering condoms, lube, STI test kits, HIV test kits, thinking of these as a package, which is how we should be delivering all of this. I want to call out, I know we're streaming to Northwestern today, and so I want to call out Brian Mustansky, who has led, I think, the most sophisticated e-health intervention that focuses on young MSM called Keep It Up. If you haven't read this paper, I just think it's an amazing piece of work that Brian did. And part of this program, this is for young MSM who've just tested HIV negative, and they have a series of seven visits but mailed out specimen collection kits at the beginning and the end for STIs. 1,113 kits were mailed out, and 89% of those were returned with specimens and analyzed. This is 18 to 29-year-old young MSM. So I just want to emphasize how highly acceptable this is for the group that I mentioned on the first slide that we really need to reach. The rectal STI prevalence was 12.9% with a racial ethnic differential. And then in terms of testing, I know this has already been covered, but I just want to say from an implementation perspective, syphilis is also challenging because of some of the limitations of diagnostic tests. So one is this idea of serofast syphilis and that it's so common in MSM, these low titer, distant infections. So it becomes a multi-step algorithm in any case. With mail-in specimens, it's the only one we have to have a bigger quantity for. It would be great to be able to get a result from a dried blood spot. So all of you are thinking about SBIRs and innovation. We will be your customer. INSTI has licensed in Europe a multiplex assay, which is HIV 1, 2, and syphilis. And so I think this idea of structurally bundling the testing together, and the price point is not that much more. So again, thinking about how we get this testing to be done together and close that gap between HIV and STI testing. And then the last thing I'll introduce is that these rapid assays have varying sensitivities. And so my question is whether that's a feature or a bug. If you have a test that is less sensitive, should we encourage manufacturers to work on getting that sensitivity up? Or for MSM, would we actually like a test that detuned is not the right word, but that because we know that there are these low titer cases, especially if you're screening regularly, might there be a benefit to having a slightly lower detection so that we don't have to keep intervening on serofast cases, with the idea that if they're testing every 3 months, they would be back in 3 months when the titer, if you're catching it on the way up. And then last, I want to mention PEP for STIs and just put this into the mix. So you guys probably have all seen and been excited about the work from Ipergay, Molina et al. This is a subset of the Ipergay participants who were offered STI PEP. And this Kaplan-Meier plot just shows the STI cumulative probability of syphilis infection, for these men. And the lower blue bar is the men who were on post-exposure prophylaxis, a single 200 milligram dose, 24 hours to 72 hours after their exposure. And so they had a significant reduction, 87% reduction in the risk of syphilis. Chlamydia had similar results. Gonorrhea, as expected, had no effect. So this will ignite another great debate, and I'll just put up some of the questions. Do men want to use it? Indications are some do. What will happen to docycycline resistance, either for gonorrhea or for other pathogens or other organisms in men who take it? Will men remember to take it? Will they have it when they need it? They're harder than condoms to keep. The capsules are harder than condoms to keep in your wallet. Will risk compensation result? Who should provide these? How does this play with HIV PrEP? Should men be on both? Are there any clinical issues we need to think about? And you can fill in a bunch more skeptical questions about this. So skeptical questions are welcome. So in conclusion, I just want to say that we started out talking about the idea that when we talk about implementation science, to me, it's just this broader consideration, not just of the clinical features and of the likelihood in patient populations, but the epidemic state, understanding the service settings, understanding the opportunities, how can we access the people at risk, and the goals for syphilis, addressing syphilis epidemics are going to be different based on all those aspects. And I think it's fine to have one goal for congenital syphilis and another for men who have sex with men and another for heterosexual men and women. MSM are most impacted by the current increase in syphilis diagnoses, and better surveillance systems are needed. I think that means just getting basic risk information about sex of partners, but also things like trans, gender identity, sexual orientation, gender identity. We need better rapid diagnostic tools for syphilis. Mail-out approaches offer promise for bringing to scale, and thinking about younger MSM who are notoriously bad at going to providers, as well as rural men who may not have access to providers who are aware of rectal STI screening or that would require discussion they don't want to have in their local community. And STI PEP is on the tracks. It's especially efficacious for preventing syphilis. So is this a game changer, or is this another shiny object? And I think it's up to all of us to think about this, again, in terms of the who provides it, where is it provided, who is it provided to, how does it go along with the other things we need to provide. The amazing thing about doing this work is getting to work with amazing people and having amazing funders. And so thanks to those people, to those funders, and to you for having me here today. Thank you.
Great. Well, I just want to open the floor. We have about 10 minutes for questions. I'm sure folks may have some.
I'll stand, I guess, because... Is it on? Can you hear me? Okay. Patrick, great talk. We heard some very interesting things, so if you don't mind, I'm going to ask two questions. We heard very interesting topics this morning. One question that Khalil brought up is the impact of the docycycline on the biome. And what we may or may not know about that and how that might impact use of docycycline for PEP. Maybe you could share your thoughts on that. And then my second question, which is unrelated to the first question, I apologize, but really thinking about young black men who have sex with men. There's been some good data that looks at racial disparities, barriers to care, particularly around disclosure of sexual orientation, sexual behavior, and the fear of disclosing and being stigmatized and marginalized. And how do we really address that? It's great that those questions are going into surveillance, but how do we do that clinically and practically in real world settings where people may or may not be seeking care?
So for the first one, I just want to say, I think the questions about this is true of STI PEP, but this is true about everything that we've been doing for decades. And so I think the understanding of the biome, the methods to study it are advancing. My colleague Kelly is really looking in great detail at things like the effect of condom-protected or non-condom-protected anal sex on microbiome, on rectal microbiome, and so I think this is definitely one of the areas that should be part of investigations. It's sort of specimen intense and it's sort of money intense, and so I think just there might be maybe there's a mechanism through supplements or through some other kind of mechanism where this may be studied. To collect those kind of samples. I think it's a great point. For young black MSM, I just want to put out a couple of data points about that. In terms of the barriers, I think that a primary one is just around disclosure. And again, in big cities where there are magnet programs, men have more alternatives. I would say that my colleague Jeb Jones did some work with CDC just around to get the preferences of providers and men for doing some of these screening questions, either on their phone before they come in, or in the lobby on an iPad, and it was very acceptable. He developed a little app on an iPad, and so we focused on sexual health and gender identity and sex partner issues. And they said, actually, we love this, but why didn't you ask me about substance use? Why didn't you ask me about smoking? Why didn't you ask me about alcohol? So I think there's a real willingness, and I know that EMR systems are moving along towards this, but we just know from research methods and from common sense that men may be more likely to put that into an iPad than to tell their doctor, and we know that doctors are often not comfortable asking. I think giving doctors scripts, this is recorded, so I maybe shouldn't say this, but it's true that I have a gay physician in Atlanta who is very, always wants to know what's going on in HIV research, and I worked on the STD testing guidelines back in 2006, and so when they came out, I went in for my annual visit. He said, I'm not sure what I'm supposed to do because I know you worked on those. I know I'm supposed to ask you. So I said, look, just say I'm going to test your blood sugar, I'm going to test your cholesterol, I'm going to test you for HIV. Is that, because that's what we do. And I said, like, no, say it. So he did. And then I have a friend who goes to the same doctor who, and I didn't tell him about this, and he contacted me and said, hey, guess what Dr. S said to me? I'm going to test your blood sugar. So I'm not, I don't know, I'm not a clinician, I don't know about messaging, but I just think giving doctors scripts so they know, the other one is, are you having sex with men, women, or both? And so sort of integrating that. So one is a sort of depersonalizing a little bit. One is giving doctors scripts and normalizing it. And so I'll leave it to others. Implementation science is a team sport. The other thing I'll just mention about barriers is that there are additional, when we talk about young black MSM, just want to call out, 073 and the sort of C4 intervention that they developed as an example of interventions that are really informed by the communities that they're meant to serve. When we look at guys who discontinue PrEP, when we look at guys who have trouble keeping on their visits, in Atlanta they're often about transportation. we have a concentration of black residents in Atlanta in the southwest quadrant where the buses coincidentally only run once an hour and where the routes are sparse. And so for them, we say, like, we're right on the MARTA line. It's like, well, it's an hour to wait for the bus and 30 minutes to get to the MARTA station. And so we've just been doing Uber rides, like, to the closest MARTA station, which may be a $6 Uber ride, but then it gets them on the line and they're there in 20 minutes. So I just think it's all of the above. It's culturally competent services, but it's also just addressing the basic needs. We've shown that basically in Atlanta, the farther away, greater your commute time to your care visits, if you're living with HIV, the more likely you are to miss follow-up appointments. That seems obvious, but it's part of the picture.
Hi, my name is Adina Greenbaum. I'm one of the assistant commissioners at Baltimore City Health Department. And I don't really know how to phrase this as a question. I guess it's more of a comment, but this type of implementation science work is so important to the work that we do, so important to coming up with effective prevention activities. And we are so lucky to have such good partnerships with our local academic institutions and work closely on these sort of problems. But a real challenge that we're facing is research fatigue, especially in the Black MSM community and a little bit in the injection drug use community as well. And Baltimore is a medium-sized city. There are only so many Black MSM living here, and I certainly can't say that everybody feels like this, but we certainly do hear and are hearing of just fatigue of constantly being approached, this same population being approached for study after study, whether it's in conjunction with the health department or not in conjunction with the health department. And the lines are blurred, from some community members' perspective, whether it's an academic institution or the health department, it doesn't matter. It's the same question being asked. And the challenges that we face as a health department in preserving the community's trust in order to address public health emergencies when they are true emergencies is probably one of our top priorities. And for example, we're working closely with CCHR here on exploring those issues and trying to dive into them a little bit more and see how we can approach them together. But I guess I would just mention that is one of the challenges that we're certainly facing with some of this type of work.
So I think this is a great point. I have to say that my sense in Atlanta is that there's still a lot of active interest in these projects. I do think that our geography and our population is bigger, and we're somewhat of an accumulating point for Black MSM. Gay folks roll downhill into Atlanta when we get out of high school in the South. But so I think part of it's population size. But the one, there's a couple things that I think are helpful. I know you're already doing this, but thinking about community advisory structures as a way to bring these concepts up and ask how they might best be introduced. I like your idea of somehow characterizing them so people get used to thinking about this is an urgent public health response and we need you to, or it's a drug-resistant strain of something, and so we need to do partner notification or whatever, versus this is a longer-term research study. The other thing that we do that could have an application here is because we run a number of studies at a time, we do a generic screener when we go to events. So we screen men, and that's screening them for 7 or 8 studies. If they're eligible for 2 of them, we may just say, we have 2 things going on. One is you test a mobile app, and one is you wouldn't have to test anything, but you just come in over a longer period of time and give them some agency. And then we also, for our multiple studies, we also keep a database so that if we screen someone, that they're not eligible for multiple enrollment. So it's sort of like once you've gotten into one study, we'll help resolve that, so we're not, we wouldn't offer you enrollment in another, which I think also is a rigor issue just in terms of duplicate enrollment. But I think that if you're talking to the community and community advisory board and just saying like, how do we prioritize these, that's one piece of input. The NIH system, because we all are submitting, we know we have to submit 4 or 8, 10 proposals for every one that comes in, and we, like academically, we need a certain number. There is just a proliferation and a focusing on this population, and we don't always have time to coordinate at the concept level all those. It's not until they get funded and then you say, okay, this is the one that made it through, and how is that going to fit with everything else that's going on? It's a great point, but great to hear about your academic, your sort of trust in that academic relationship, and that's an incredible resource that many areas continue to work to build.
Right, so maybe Homi will have the last question.
I was wondering if there is any data on incidence and prevalence of resistance to doxy in general population versus those who use it as PrEP?
Yeah, so the question was about prevalence, incidence and prevalence of resistance in those who use it in the general population. I'm not aware of that. I think that is the right question to ask, is because there is in the iPergay study, there was, I think, 4 of the 9 gonorrhea infections in the STI PEP arm had resistance, and 1 of 12 or something in the other arm, 1 of 30. So there's quite a difference in the iPergay study, but I think you're putting in the broader context, which is doxycycline is also used for other purposes where it's given in these bursts, and so whether it's malaria prophylaxis or for other conditions, and so I think one is to think about the general population. I think the other is not just to focus on the STI testing, the STI, like the gonorrhea resistance, but also sort of other colonization. Like, are we selecting for resistance in other organisms that are living in the body? And so I think this is just going to be a major question about the risk benefit of this, and you raise a great point.
Great. Well, I want to thank Patrick